Good day to everyone. My name is C.B. Mamaril, and on behalf of the Systems for Action National Program Office here at the University of Kentucky, I'd like to welcome everyone to today's PHSR Research in Progress webinar, focusing on the cost, quality, and value of public health services. And today, we'll have two presentations coming out of this center. They relate to the economic, organizational, network variation in public health services delivery. And so some of you may notice there's a new look to who have been following our PHSR webinars, that there's a new look to our webinar today, and that's because we're trying out a new web conferencing software. And so without any further ado, my presentation will sort of be the test run for using this software. And so again, on behalf of the researchers, my fellow co-researchers, Dr. Glen, Keith Branham, Lava Tinsina, we'd like to thank you again for joining us as we present the work that we've been doing here at the center in estimating the costs of providing foundational public health services. And today I'll focusing our talk on the model simulation approach that we've used to estimate these costs. And so before I start, I'd like to acknowledge the funding and support of the Robert Wood Johnson Foundation for this project, as well as for the Systems for Action National Program Office. I'd like to give special thanks as well and express our gratitude to our colleagues at the Washington Practice-Based Research Network, particularly the Delivery and Cost Study Research Team led by Dr. Marlowe and Dr. Beckemeyer, who are also leading one of our directed research consortiums. We'd also like to acknowledge the work of the Public Health Leadership Forum, something of which I'll talk a little about later, and also the assistance of our graduate students here at the University of Kentucky. We also want to especially thank Dr. Georgia Heise for the help that she's also provided and assistance she's provided with us in coordinating the cooperation of the Kentucky Health Departments Association, as well as Terry Allen in helping coordinate as well the assistance and participation of the Association of Ohio Health Commissioners. So the work that we've been doing in estimating the cost of these foundational public health services really are part of a broader effort that's been going on to gain a deeper understanding of the costs and returns in public health. And this effort was highlighted really in a 2012 Institute of Medicine report that laid out those recommendations of the need to identify the components and costs of a minimum package of public health services, particularly in defining and identifying what those foundational capabilities are and the area of basic programs that those capabilities would be supporting. Also notable in that report was the recommendation of the need to develop and implement a national chart of accounts for tracking the spending and flow of these funds, and really broadly expanding the efforts into the research on costs and effects of public health delivery. And there's been a lot of notable efforts that have been going on in the various states of trying to really define and costing out this public health package. Some of those notable efforts have been the efforts in Washington State to cost out their foundational public health services, the initiative that the Ohio Public Health Futures Committee led in costing out their minimum package of services, as well as the effort that's in Colorado in costing out their core public health services. On the national level, the Robert Wood Johnson Foundation formed the Public Health Leadership Forum to convene a national work group on defining and articulating what these foundational public health capabilities are. And that work is well documented and is also available and can be accessed and downloaded from the Resolve website. The Resolve was the group that helped coordinate this national work group. So many of you might be familiar already with what these foundational public health services are, but just to sort of refresh those or familiarize those who are not as familiar with it, we define these foundational capabilities as these cross-cutting skills that need to be present in state and local health departments everywhere for the health system to work anywhere. So you often hear that phrase associated with foundational capabilities of everywhere and anywhere. Foundational areas are those substantive areas of expertise or program-specific activities in all state and local health departments that are essential to protect the community's health. So when we combine them, we broadly refer to them as foundational public health services. Some of you may be already familiar with the framework, and this graph sort of provides a good illustration of that framework. As you can see at the bottom of the graph, those foundational capabilities cut across in supporting the different foundational areas and should be available or found in every local health department. And keeping in mind that what may be foundational in one community may not be also foundational in another, we have these dotted line that cuts across the different foundational areas. So everything that's below the line is considered foundational and should exist in every local health department. What is existing above the line would be considered more specific or foundational to each community. So in conjunction with that work group that led the effort to articulate and define these foundational capabilities, another work group was convened to develop the methodology for estimating the cost of providing these foundational public health services. And a report was released on the recommended methodology, and that's available for download too as well. We had the opportunity to pilot test that methodology sometime in the summer of 2014 with the help and cooperation of the Kentucky Health Department Association, which formed the finance work group comprised of 6 Kentucky health departments. And the results from that and the feedback allowed us to, again, pre-test a second iteration of the methodology with the help of selected Ohio local health departments with help and cooperation of the Association of Ohio Health Commissioners. And last year, sometime this summer, we launched a national survey in order to collect data from other states too as well, and that effort is still ongoing. And so to briefly summarize and focusing this talk today on the methodology that we use, this slide shows us sort of the basic process flow, and that's why we are grateful for the contribution from our colleagues from the Washington PBR and DAX research team who developed a data collection instrument which we adapted and modified accordingly. In summary, essentially what we do is we provide our respondents with the document that defines and articulates these foundational public health services and ask them, based on their understanding of how these areas are defined and articulated, to provide us with the information or data that we use in estimating first their labor costs and their non-labor costs. Where we differ from the approach used in the Washington DAX study, which took a more direct approach in estimating those costs associated with projecting what full attainment would be, is we took a needs assessment approach using a current attainment scale. And this graph sort of illustrates essentially the principle or concept behind how we estimated the projected need of those costs, where we asked our respondents, based on their understanding of how each public health foundational capability and foundational area is defined, we asked them to provide a global or overall assessment on the following question. So for each foundational category, what would be the estimated percentage currently being met by your health department? By providing that information and knowing what their current costs are, looking at the graph, we're able to have an idea of where point A would be on that graph, or the cost at current attainment level. And by doing so, we're able to empirically derive point B, which would be 100% or the projected cost of full attainment for each particular foundational public health service. Now, as many of you are familiar with who have administered surveys, health departments are already overburdened with survey requests, and there's already essentially an inherent burden in administering a complex survey, especially as it relates to collecting data on costs. Even as we try to make it as efficiently self-administered as possible, we try to take or develop a pragmatic empirical approach that accounts for the variation in these costs due to the inherent dynamic nature of public health. As you know, the supply and delivery of public health services and demand for these services do vary over time, from day to day, from week to week, and throughout the year, and varies from community to community. So we took a simulation modeling approach to estimate this cost that allows us to model this variation, including having context into the uncertainty associated with these cost estimates. And this approach really can be summarized as generating a probability distribution of these costs, which is the range of all possible cost value, and estimating the likelihood of their occurrence. And so in generating these input costs, we're able to calculate these output values from all the possible combinations of these input costs. And the nice thing is that since these probability distributions can be graphed, they serve as a useful aid for analytical decision-making and planning purposes. And so this next slide shows us, provides a visual representation of one of those actual simulations of how we generate, or how those probability distributions for our input costs are generated for both labor and non-labor inputs, and our outputs being the total costs across each of the different foundational public health services, and then being able to add them all up to generate a distribution for our total foundational public health services costs. So this sort of gives a visual summary of the approach, the model simulation approach. So in these next few slides, we want to present some of the population-weighted per capita cost estimates that we had from our survey of local health departments in Kentucky and Ohio, and really show how it is used to evaluate the variation in the cost of providing these foundational public health services. So this first slide shows the aggregate estimates for the full sample. And so the upper left-hand slide shows the probability distribution for our current per capita costs. And the way to interpret the graph would be that there's a 90% probability that the current per capita costs of providing foundational public health services is somewhere between $50 to $76 per capita, with the most likely value being around $62, $63 per capita. The upper right-hand corner of the graph shows the probability distribution of the per capita costs for having full attainment or meeting the full need for providing these foundational public health services. And you could interpret as saying that there's a 90% probability that these costs are somewhere between $77 to $137, with the most likely per capita cost being about $106 per capita. But the true usefulness of this approach is when you overlay these probability distributions and where it adds context to the estimates, because then you're able to visualize or have a visual representation of those variation, and at the same time be able to evaluate the gap between those current and per capita costs. Not surprising if you see at the bottom graph that there's a tighter distribution associated with our current per capita costs, and the wider distribution associated with our projected per capita costs, suggesting a greater level of uncertainty with those estimates. We also do sensitivity analysis, and there's two ways that you could visually display the results. This tornado chart ranks those inputs based on their effect on the output mean. And in this case, our two biggest cost drivers would be the labor costs associated with our maternal child services and the labor costs associated with those organizational competency capabilities. The spider graph below shows the change in the output mean, how it changes across the range of input values. So the steeper the graph, the bigger effect that input has on the output mean. But we can also disaggregate those variation and look at the variation of those costs between states. So we have Kentucky in blue and Ohio in red. The top graph shows the distribution of those costs as they relate to the current per capita costs, and would suggest that our current per capita costs, average current per capita costs for our Kentucky site is much higher than the cost estimates from our Ohio survey site. But what's interesting to know is that these are weighted population estimates, that when we look or overlay the graphs of the projected need, that the projected costs or the distribution of these projected costs follow each other closely for both sites. We're also able to disentangle that further and look at the variation within each state as we overlay the costs or the distributions for our current per capita costs and the cost for those projected needs, and again, look at or evaluate the gap between those two estimates too as well. And even further, we can also look at the variation for each foundational public health service category. So taking the example of the cost distributions for providing environmental public health service in Kentucky, the graph overlay results would suggest that the current per capita costs of providing environmental public health services in Kentucky already are closely following or aligning with what the projected costs would be to provide those environmental public health services in Kentucky. Taking another example from Ohio, for example, with regards to the community partnership capability, the graph overlay here then would also suggest that those current costs are already closely aligning or following what those projected costs would be to fully attain those community partnership capabilities in our Ohio site. Another value to this methodology or approach is that it also allows us to incorporate additional information, especially as we collect additional data from other states. In this example, we're again grateful to our Washington DAC's research team that shared with us their aggregate results from their study, and we incorporated that into our sample too as well, and we get to see how that also changes the distribution of for our current per capita costs and the per capita cost for our projected need. The small graph you see at the top part shows when this information is incorporated, shows again the gap between the current costs and the projected need costs, and also the associated variation in these estimates. We were also interested in seeing how those estimates differed between each other, and the lower left shows gives an idea of the variation associated with the aggregate estimates that were collected out of Washington, comparing that with the aggregate estimates that we had from our pilot site, and would suggest that our site had a higher per capita costs. And the lower right-hand graph provides us also with a perspective on the variation associated with those estimates as they relate to the projected costs. So it's interesting to note that in the case of Washington, they do have less variation associated with their projected estimates, and this would be interesting to see if that is a function also of the methodology. So these are just some of the things or areas that we can look into in evaluating the variation associated with these cost estimates. And so being able to demonstrate the feasibility and value of this hybrid cost estimation methodology is quite useful, because it allows us to add context again when we estimate costs by at least providing some information on the variation of these costs in implementing these public health services, which could be very useful for analytical decision making and policy related purposes. So with that, I'd like to stop and introduce our guest commentator today, who can speak a little to how this work has informed some of the work that she's leading here in Kentucky. Dr. Georgia Heise, who's the director for the Three Rivers District Health Department, which is one of the first health departments in the nation to achieve FAB accreditation. Georgia serves on the Executive Committee and Legislative Committee for the Kentucky Health Department Association, and chairs both its Strategic Planning Committee and Foundational Capabilities Work Group. She's also been a mentor for a Balderson Award-winning Kentucky Public Health Leadership Institute project and is a fellow of that institute. Georgia is also an adjunct faculty member for the University of Kentucky College of Public Health, and also co-directs the newly established Kentucky Population Health Institute. Beyond Kentucky, Dr. Heise is immediate past president of the National Association of County and City Health Officials, and she's always been passionate about advancing public health through accreditation, governance, and policy development. She speaks and trains nationally on these topics and others. So with that, I'd like to turn it over to you, Georgia.
Thank you, CB. Good afternoon, everyone. I would like to talk just a little bit about how this is rolling out to further work in Kentucky. As everyone knows in Kentucky, our health status is not very good. We are 44th out of our 50 states, and we are about 15th in spending. So we're not getting good bang for our buck there as compared to our state, sister state, I guess, in Washington. They do better. They are 9th, I think, in health status. I'm not sure about Ohio. I don't think theirs is that good, but it was very interesting to see how these numbers look in comparison to dollars actually spent and where the dollars were spent in the name of public health. We spent $300 million in Kentucky last year. The $300 million, however, the majority of that was not on foundational services. It was on one-on-one clinical services, for the most part reimbursable by Medicaid. So we have a budget that's kind of similar to what the projections are that it would cost to do the foundational services in Kentucky, but we're spending those dollars on something other than those services, and then the reimbursement that we're receiving, that source will not reimburse for the foundational services. That's a little bit of a problem. So this is, research points straight to that. Now, making sure that legislators and people who are able to direct funds understand that is a little bit trickier. Sometimes the pretty blue and red graphs, they're not that easy to have a legislator to sit down and read those and try to understand what they mean. Given that, the health department directors in Kentucky have taken the work that Glen and CB have been doing and taken a little different approach in terms of, we've looked at, if we were to try to establish the minimum size of a health department in terms of bodies, public health professionals who could perform the services, what would that look like? We handed to CB and Glen the challenge of what's the best statistical tool to use to make that determination in terms of the size of health departments that we have in Kentucky. Right now, they are just a matter of choice and what has happened over time. There has been no work done determining the best functioning size health department we could have would serve 100,000 people. There's nothing that says that. We've done no work. And in related to that, in Kentucky we have 27 health departments who serve a population of less than 35,000, 23 more that serve a population between 35 and 75, 4 that serve between 75 and 200,000, 4 more that are between 200,000 and 350, 2, 350 and 450, and then we have our biggest one that's 750,000 people. So you can see we have tiny health departments with literally a handful of employees, and then we have great big health departments that have 300 plus employees. And the services that they're doing, like CB mentioned, are all over the place in terms of the foundational services and then a whole variety of other things that over time they have either received funding to do, whether they really needed to do it or not, or the community determined it was a need and was willing to ante up the money for it. So we don't really have a standard set of services in Kentucky. What we do have, though, is statutory requirements that line up really closely with the definitions of the foundational services. So going from that, we can say that Kentucky directs us by law to do the foundational services. However, Kentucky funds us to do something different, which is the individual clinical services. So there's the rub. How do we move from funding for a service that we're not required to do by law to gaining funding for a service we are required to do by law. We are working on that. We would like to, next session, be able to give a more accurate plan to our legislators about this is what that would look like. We have started on this work already, as I mentioned, and we have been talking about it during this entire legislative session. Our session is ongoing right now, and a group of us have been all over the legislators with what we call the Little People paper, which defines our health departments or the work we've done so far as to what size health departments we think we need in order to deliver the foundational services. And we're really hammering on the foundational services. These are the things that we want to do versus all the other services that we have been doing. It's not that we don't want to do some of those. We do. Those are important services. However, they're not the foundational services, those that have no money, those that are required by law. So this work that started with that report in 2012 continues on. It's gaining a lot of attention from a lot of different people. More and more states are picking it up. In fact, Washington State has invited a group of directors from Kentucky to attend their conference, which would be, I guess, their health department directors conference in June, and so we can all go out there and discuss this. The difference between Washington State and Ohio, to some degree as well, and Kentucky, is that was kind of a state-led initiative, whereas in Kentucky we started with a handful of health department directors and Glen and CB to work on this. Washington State has looked at it from a statewide effort and to a lesser degree had their locals involved in it. So for us to sit down and look at our findings together, that's going to be very telling, I think, and very helpful as we move forward. This is where we are going in the future. We can't afford to do anything else. So I can say that sitting at my desk looking at my budget for my next year and tell you we can't afford to go anywhere else. So how's that, CB?
Thank you so much, Georgia. And I'd like to take note that Georgia's efforts with their finance work group that they formed when we pilot tested the methodology sort of also had a proof of concept of how a national chart of accounts might look like in terms of each state having their own chart of accounts because they first crosswalk those foundational public health services framework with the existing chart of accounts that is currently in place for Kentucky and use that as a starting point to try to track the expenditures for be able to allocate those costs according to those foundational public health services as defined by the national work group. So again, Georgia, thank you so much for sharing those insights, and we really look forward to collaborating with you more in the future. And before I turn it over to our next speaker, I just want to quickly address the question that Patrick typed in, that how we sort of estimated the point B or full attainment. Yes, so we use that essentially, that graph is essentially just showing the principle of concept of how we got point B instead of directly estimating it, because we wanted to minimize, sort of the potential bias that would arise if you asked a health department how much more would they need to meet those or fully attain those public health services. So based on that information, we do still apply the simulation approach in generating a distribution of what those projected costs would be. So yes, so the question of Patrick was how do you determine the distribution? So there is a limited number of observations, and so what we ask our respondents is we assume a triangle distribution. We ask them to provide their estimate for what a minimum estimate would look like, or what a maximum estimate would be for a particular public health service category, the cost of providing that, and what would sort of the average or most likely cost estimate would be. So having a triangle distribution, we then simulate or sample across that distribution in order to create a distribution of inputs and calculate our outputs too as well. Chris asked us a question, how might the contribution of hospitals and other partners be considered in the calculation of foundation public health services? That's true too, and this is something that we haven't looked into. It's a good question. But again, with this approach, we're able to incorporate additional information. It allows us that flexibility to do that. I'd like to stop there because I'd like to give time for our next presenter, who is none other than our director, Dr. Glen, who is the director of the RWJF Systems for Action National Coordinating Center and is a Scotchfield Professor of Health Services and Systems Research here at the University of Kentucky College of Public Health. Glen also serves as the director for the Center for Public Health Systems and Services Research within the College of Public Health and is also associate director of the Center for Health Services Research within the College of Medicine. His research focuses on strategies for organizing and financing public health services, preventive care, and care management systems for underserved and high-risk populations. And previous to his arrival in Kentucky, Glen also chaired the Department of Health Policy and Management at the University of Arkansas for Medical Sciences for 8 years. So with that, I'd like to turn it over to you, Glen.
Thank you, CB, and thanks again. Great to hear both CB and Georgia talk about this this really interesting work in both defining these foundational public health services and capabilities, and then generating first-generation estimates of the resource requirements for establishing them. I'm going to talk a little bit about some of the work we're doing to try to begin to answer the next question that often comes up when you're talking about these foundational services and how much they cost, how much it costs to to establish them across the state or across the community. The next question that Georgia I think often gets when she's working with our policy stakeholders and even with public health officials around the state is, well, what can we expect to gain from strengthening these foundational services and capabilities? And also, I think some questions implied in Chris Malin's chat box comment about how do these foundational services relate to other players in the larger public health system, whether they be hospitals or others. And so I'm going to talk a little bit about some of the work that we're doing to begin to look at those kind of questions of potential health and economic effects that are attributable to having stronger foundational public health services, and also how these services connect into the larger networks of organizations that contribute to public health services. I'm going to go through these slides pretty quickly. I'm not going to spend time on all the slides that we've got up here today, but you can certainly download these and take a look at them in more detail if they're of interest. This work I'm talking about today is actually part of a panel that we presented a couple months ago right before the holidays in December at the NIH Dissemination and Implementation Science Conference. A great panel we put together with our colleagues at the University of Colorado on these issues of basically the economics of implementing public health services. Again, I'll go through a few of these slides. There's more here that I'll skip through quickly, and again, you're welcome to take a closer look offline. So again, obviously we are grateful to the Foundation for their support of this work, and our great team here at UK has contributed to this work. So the foundational services, public health services, are about primarily governmental public health capabilities. But we know ultimately this is about population health, how we improve population health. And we know through a lot of work that's now focusing on population health improvement that improving a health level population is going to involve getting large-scale improvements, getting to targeting fundamental and often multiple determinants of health, and therefore getting lots of different actors in the health and public health sectors better into alignment, figuring out how to organize collective actions across sectors to support work that improve population health. So we're talking about mobilizing work far beyond the public health sector. And we know from Eleanor Austin's work and other people who study collective action problems, whether they're in public health or healthcare or other elements of other areas of social activity, that there's lots of reasons why organizations don't often work together and are not well aligned in their work. And so part of our challenge in public health is to figure out how to overcome some of these collective action problems that people like Eleanor Ostrom, a Nobel Prize-winning economist for her work in this area, has pointed out over time. So the question is, can these foundational public health services, which are governmental responsibilities, can they help us? Can they provide infrastructure for mobilizing multi-sector collective actions around population health? And we think conceptually, at least, they should. I mean, this shows you the basic public health model, and this slide kind of another way of thinking about displaying these foundational public health services. These foundational services and capabilities allow make sure that in every community we've got the ability to assess health needs and risks, to link those risks to the evidence base and make recommendations around what programs and policies to put in place, then to develop the plans and policies for implementing those recommended strategies that are targeted to those identified health needs, and then doing the collective action work of mobilizing actions, getting stakeholders together across sectors, public and private, to play a role in implementing strategies, recommended strategies, and managing the division of responsibility and resources across that. And then playing the critical role of monitoring progress, evaluating the work, feeding back measures of progress back into the system and back into the stakeholders to sustain efforts over time. That's ultimately what the foundational public health services are about. Those are about measuring the governmental public health capabilities to support this kind of work, which should strengthen overall the ability to implement those multi-sectoral population health improvements. So we've been interested in studying, again, how these foundational services relate to the work of other actors in the public health system, and looking at network effects, looking at how those contributions change over time, and looking at, again, ultimately how changes in foundational services and the result and the delivery system that support those services, learning how those changes impact population health, potentially impact both health, understanding both the health and economic effects of those kind of changes. So many of you are familiar. We do have an opportunity. One lens that we can use for studying those kind of issues is our longitudinal survey of public health systems that many of you in PHSR are familiar with. This turns out to be a pretty useful lens for studying these foundational services, for studying contributions in both public health as well as contributions from other sectors to these services. And by monitoring those contributions over time, it gives us a way of looking at, estimating how some of these foundational services potentially affect health and economic outcomes over time. So we now have a 16-year span of time where we're able to track delivery of foundational public health services from this survey. Again, a cohort of about 360 communities that we've been following over time, beginning back in 1998, and we periodically resurveyed those same communities. We ask about a range of 20 public health activities, whether or not they're performed in the community, and fortunately those activities link up align very well with the foundational public health services definition that CB and Georgia talked about. This gives us a way of measuring foundational public health activity on the ground in a large cross-section of communities. We also ask about the range of other organizations that contribute to those activities, both in the public and the private sector, including CRIS, hospitals, community health centers, employers, insurers, schools, other CBOs, faith-based organizations, etc. We also get a measure of specifically the governmental public health role in supporting those activities, and a measure of quote-unquote quality, a measure of perceived effectiveness of each activity, how well each activity is implemented based on the perceptions of a local health officer. We did expand this wave of the survey in 2014 to include a large new cohort of smaller and rural communities to do a better job of characterizing those places that Georgia was talking about that are so prevalent in our state and lots of other states, especially in the South and Southeast and in the Mountain West, rural and smaller communities, lower resource communities. So we were able to link these data with lots of other data sources that tell us more information about community resources, more information about other institutions that are available in the communities served by these areas, hospitals, physicians, and others. And importantly, we're able to link these data with measures of health status, preventable mortality in the case I'll be showing you here, and also measures of resource use, such as expenditures by governmental public health. And also we've linked it to measures of medical care expenditures from the Dartmouth Atlas. We've linked it to measures of hospital uncompensated care delivery from the CMS cost reports. So we can look at lots of potential relationships and how changes in the public health system potentially can relate to changes in important health and economic outcomes over time. Again, now over a 16-year span of time at this stage. So again, some of you have seen this work before. We can use these data to characterize the systems that support foundational services using network analytic measures like you see here, looking at the range of organizations that contribute to the foundational services that are measured in our survey. We've done cluster analysis to basically sort the country, sort U.S. communities into one of 7 types based on the structure of the public health delivery system, based on how many of these foundational services are delivered, and based on the range of organizations that contribute to delivering these services. And the first 3 of these clusters are what we call comprehensive public health systems because they deliver the broadest scope of these foundational services, and they do that with through large, pretty dense networks of interorganizational partnerships among a variety of organizations in the public and private sector that contribute to performing these services. So that first 3 groups of systems we call comprehensive. And we've done some work recently to, again, look at changes over time and the prevalence of these comprehensive systems, and then look at how those changes, as more communities move into or out of a comprehensive status, what happens to health status, what happens to resource use in those communities, using, of course, lots of fancy econometric models. We do see quite a bit of change in the comprehensive public health system status over time. We're now, as of 2014, you can see in the next to the last right column, we had about 47% of the U.S. population that were residing in a community that was served by a comprehensive public health system. That represents about 1/3 of the U.S. communities in our sample. As the last column shows, the prevalence of these comprehensive systems are a bit they're less prevalent in smaller rural communities of less than 100,000 population, not surprisingly. And again, we've seen some changes over time. We made rapid progress in the late 90s, early part of the 21st century with these moving toward more comprehensive systems. We hit the recession. We saw decrements. We're starting to see some slow signs of recovery, more communities moving back into comprehensive status, but still a lot of variation. And I should point out that this measure of comprehensive public health system is one of the Foundation's 41 national metrics for tracking progress toward a culture of health. So this measure is now one of the Foundation's national culture of health measures. We will be using this measure as one signal of momentum toward building a culture of health. So what are we learning about the health and economic impact or consequences associated with comprehensive public health systems that deliver a broad scope of these foundational services? Well, again, I'm running out of time, so this slide shows you the measures of health outcomes and resource use that we use for these analysis, basically preventable mortality measures, and then in this case using local government expenditures for public health from the NACCHO data as our measure of resource use. And then we use our network characteristics and comprehensive public health system measure as our primary independent variable of interest to estimate how movement to comprehensive public health system status is related to health, population health, preventable mortality, and to resource use. We use fancy econometrics to deal with confounding and selection and endogeneity bias with regard to our measure of comprehensive public health system status. Obviously, richer communities more likely to achieve that status, and the economic environment also has important implications for for population health in those same communities. So we use instrumental variables estimation to deal with the endogeneity. I'm going to skip now so I can get down to punchlines. I know we're running out of time here. But basically, so what we find overall, again, not surprisingly, comprehensive public health systems, they deliver a broader scope of these foundational services, but they do so with lower overall levels of resource use. And when we look at per capita public health spending in the communities, for comprehensive systems, they deliver more of these services at a lower level of average public health spending per capita compared to the other types of public health systems. So suggesting these systems can do more public health work, foundational public health work, with fewer resources. When we look at how the comprehensive measure relates to health to preventable mortality and to public health spending per capita, again, we see evidence of potentially, real beneficial effects from having a comprehensive system that supports a broad array of these foundational services. Specifically, this slide shows you estimates from longitudinal, hierarchical instrumental variables models. And what we see here is that as the effect of moving to a comprehensive public health system classification, that movement is significantly inversely related to infant mortality, to diabetes mortality, and to the overall level of premature mortality. And the effect sizes here, we're looking at the effects over the 16-year time horizon here. These effect sizes are not trivial. And so on average, communities that move to comprehensive system status over that 16-year time period saw about a 30% reduction in their premature mortality rate relative to communities that stayed at one of the non-comprehensive system classifications. And again, that last column there on the right shows you that again, the same communities that moved to comprehensive system status also saw about a 13-14% reduction in their per capita public health spending, their resource use, compared to non-comprehensive systems. So again, the overall message here is in one that there's potential real health and economic benefits from systems that over time can move to this more comprehensive public health system status that supports a broad array of foundational services through a dense networks of organizations that support these activities. And we also find that the effects are even larger when we look at low resource communities. The effects of moving to comprehensive public health system status, even larger gains in health, larger reductions in resource use in communities that are, in this case, low in the bottom 20% of communities based on per capita income, much larger effects, larger benefits from comprehensive system status. So with this work, again, we're starting to try to build knowledge about potential health and economic consequences from that we can tie to foundational services and to the larger delivery systems that support those foundational services. Again, we find evidence that there are potential benefits from comprehensive, highly integrated systems. They implement more foundational services. They see over time larger gains in reducing preventable mortality, and they do so at lower levels of governmental public health resource use. And those potential benefits are even larger for low-income communities, suggesting that these foundational services and the comprehensive systems that support them may be useful in helping us to address the equity problem that we see in health status and the equity problem that we see obviously in resource distribution of health resources around the U.S. And we also find, if you're interested in the methodology, that it's very important to account for the endogeneity problem here, endogenous network structure over time, and with the using the longitudinal nature of our survey, we're able to do that. So lots more work needs to be done here. We're refielding our longitudinal survey again in 2016. We'll get a fifth data point. We'll have an 18-year time span to work with now. And again, we've got an expanded sample of smaller and rural communities now in the survey, so we can begin to do much more granular work looking at how low-resource, small, and rural communities fare with regard to foundational services and with regard to delivery systems that support public health work. So we're excited to do that and look forward to working with all of you on common areas of interest in these research questions. So you see the last slide here, some links up about our survey and about foundational costing work that CB mentioned. So I'll turn it back to CB. I think we may have a little bit of time for some more questions if there are some.
Yeah, I think we can take one question. Elaine has typed, has the ACA and potential gains for population health related to ACA factored into the changes that you have observed in degree of coverage of community populations at comprehensive system level? So I'll turn that back to you, Glenn.
Excellent question, Elaine. We've begun to do some work looking at ACA-related effects on public health delivery. Obviously, our longitudinal survey is pretty well positioned to look at those issues because we've been, collecting data on the same group of communities since 1998. We've done some preliminary work and don't yet have much concrete to share in terms of findings. Other than to say it is kind of a mixed bag, and there are, as you know, the complexity is there's lots of different parts of ACA that potentially affect public health work, and they've been implemented at different stages over time. There's the insurance mandates around first dollar coverage of preventive services, and then the Prevention and Public Health Fund, which kicked in some new resources for a while, things like the Public Health Infrastructure Improvement Grant, but then that went away. We had some things like the community, so we've had other initiatives funded through the Prevention and Public Health Fund. Then we had, insurance expansion, Medicaid expansions in some of the states beginning in 2014. So we have some work on the way to start to look at some of those effects on public health delivery, and we'll hopefully have more on that to share soon. In fact, we've got an abstract submission into the Academy Health meeting in June to share some of those findings. So stay tuned.
Thank you, Glenn. Again, if you have a chance, you can download today's webinar and look at it. And if you have any questions, you can direct them, of course, directly to us here at the center. Again, we'd like to thank our guest commentator, Georgia, for providing commentary, and also thank you, Glenn, for the presentation too as well. We'd like to thank everyone for joining us today. Please, we invite you again to take a look at our upcoming webinars. We have one this coming March 24, which will be on the quality improvement for cost-effective sexually transmitted infection prevention services. And so we invite you to also take a look at our website. And so we look forward to having you join us again in the future. So again,
can I do a quick plug, Stevie?
Oh, go ahead. Sorry, Glenn. Go ahead.
Just 1 minute, quick plug, and I'm reminded because I see Adam Athley's name on time. We are, I think most of you should know that we've got a special issue of the Journal of Health Services Research that we are guest editing, devoted to the topic of the economics of public health delivery. We've invited a number of papers, and especially encouraged our DACs and directive grantees, other PHSR grantees who are doing work in various aspects of the economics of public health work, financing, costing, any other economic work there. We're coming up pretty soon on the deadline for submissions there, so we've been able to get a little more lead time in terms of submissions. So if we haven't reached out to any of you do have some work and papers coming together that you think might be in scope for a seriously methodologically oriented Journal of Health Services Research around the topic of the economics of public health delivery, please let us know, because we might still be able to get some additional papers under consideration. Adam and I have been reviewing early drafts of submissions, and those will be submitted into the journal later this spring. So let us know if you've got a potential paper that you might want to put in the mix. Thanks, Stevie.
Thank you, Glenn. And so with that, we thank you again for joining us, and we look forward to seeing you again in our next webinar. Have a great day, everyone, and thank you.
Thanks, everybody.